And hopefully no one will say no. All right. All right. And let's see. Are we ready to move ahead? I think I'm doing the welcome. Is that right? So I'll go ahead and get started. Laura LaCroix DeLune again with the Hennepin County Children's Mental Health Collaborative. I am so grateful to have this community conversation with our partners in Ramsey County and with Children's Minnesota, who operates in both counties. So thank you very much, everybody, for being here. I know it took us a while to come back together, but I think there's been some great work that's happened between sessions, and I'm really excited that we're bringing together practitioners and parents from both Hennepin County and in Ramsey County to this meeting. They are valuable partners in this work, and I'm just grateful that we have been able to find a time to engage our parents in this process as well. So I can turn it over to Wendy if you would like to introduce yourself, and then we'll do Megan next.
My name's Wendy Goodman, and I'm the Executive Director with Ramsey County Children's Mental Health Collaborative. And I am here with Holly, our Family Engagement Director, and with Jacinta Moss, our Board Chair and Parent Fabuloso down in the corner there. Wave hi. I think we already did some ground setting at the last meeting, but we're really excited with the partnership that's been working between our collaborative and Children's Hospital. So encouraging to see what more we can do.
Yeah, and I'm happy to jump into. Hi, everyone. I'm Megan Peterlins. I'm the Community Affairs and Advocacy Specialist here at Children's. And in my role, I have the privilege to work with people like Laura and Wendy and have the opportunity to connect groups like this with some amazing providers that I am lucky to call colleagues, and you're going to be able to meet some of them as well. And I just want to thank you, Laura and Wendy, for really helping to convene us again. And I just appreciate all of you being here as we continue this discussion that we started, if we can believe it, back in December. I can't believe it's May, but that's where we are.
And next, we wanted to just give everybody a chance to just quickly introduce ourselves, since this is really a community meeting to provide input. So if we could just briefly introduce ourselves, and would it be helpful if I call on people to move us quickly? Okay, so Jamie, you are up next on my screen.
Hey, hi everyone. My name is Jamie Winter. I am the Director of Mental Health Services at Children's Minnesota. Thank you.
Thank you. And Pam, you are up on my screen.
Hi, good afternoon. I'm Pam Ross, Director of Community Health Programs here at Children's. Really delighted to be with all of you today.
Great, thank you. And you met Wendy, who is on my screen next, and Holly.
I'm Holly Walters, Director of Family and Community Engagement at Ramsey County Children's Mental Health Collaborative.
Thank you. And Cheryl.
I'm Cheryl Holm Hansen. I'm an independent researcher and evaluator who does a lot of work related to children's mental health.
Thank you. And Margaret.
Hi, I'm Margaret Sullivan, and I'm the coordinator for the Parent Catalyst Leadership Group at Hennepin County.
Thank you. And Liz.
I'm nowhere next on my screen. So I'm I'm Liz Gronert, and I am, along with Karen, a co-chair for the Parent Catalyst Leadership Group, and also current co-chair of the governance committee for the Hennepin County's Children's Mental Health Collaborative.
Thank you. All right, Joy.
Hi, Joy Johnson-Lind from Children's, and I am the Senior Director of our Child and Family Services team here at the hospital.
Thank you. Karen.
Hi, I'm Karen Maka, and along with Liz, I'm a co-chair of the Parent Catalyst Leadership Group.
Thank you, Karen. Gigi.
Hi, everyone. Gigi Chella, Vice President and Chief of General Pediatrics at Children's Minnesota, and I support behavioral health.
Thank you. Nikki.
Hello, everyone. Nikki Helland at Children's. I'm a social work manager, and I oversee the majority of our clinical social workers doing the crisis mental health assessments. Thank you.
Thank you. Jacinta.
Hi, Hi, everybody. I am Jacinta Moss, and I'm the board chair. And as Wendy said, I'm a fabulous parent of myself.
Perfect. Thank you. Pat.
I'm Pat Dale. I'm with Headway Emotional Health Care, which is a community-based mental health and emotional health services organization. I am the co-chair of the Hennepin County Children's Mental Health Collaborative.
Thank you. And Kim.
I'm Kim Zach. I'm the mental health manager and coordinator for School District 622 North St. Paul Maplewood Oakdale Schools.
Great. Thank you, everybody, for being here. What we have next on our agenda is to just do maybe like a 10-minute introduction, a high-level overview of some of the recent research that we did in Hennepin County, and it was really focusing on how parents enter the children's mental health system. Cheryl Holm Hansen, our Parent Catalyst Leadership Group partners, specifically Liz, did a lot of the interviews, who's with us today, and then Margaret did as well. But we sent out a high-level overview of the findings, along with things that were most relevant to pediatricians or to the healthcare system, that we just wanted to quickly highlight as we move into this kind of conversation, so you know where we've been, what kinds of things we've been thinking about and talking about through the collaborative. So Cheryl, do you want to share your screen, or do you want to just talk through some of the high-level findings?
I can do a screen share. Okay, can you see the slide?
Yes.
Cool. Yeah, this is actually a really detailed and in-depth project that we did. So we're going to do just super high level. If you want to know more, I'm happy to talk separately about this, or we can share. We have shared the full report. So this is just the highlights. So this is a project that we just completed. Our goal was to look at entry into children's mental health. We wanted to do something where we were interviewing parents. And as you know, there's just so much complexity in what the children's mental health system includes and experiences along the way. So we were focusing specifically on what parents do when they first discover or first suspect that they might have a child with a mental health issue, and what is that entry point for them. What did they look for? What worked well? What problems did they face? Who helped them? And as it relates, I think, to children's, for most of the parents we interviewed, for the vast majority of the parents, hospitalization was not the entry point. For many of them, these were kids who were identified at schools or through their pediatrician, or the parent just kind of recognizing it, or the youth self-disclosing that they thought that there was a concern, and often they were looking for community-based services and supports. But we certainly had some where that entry point was also a mental health crisis, where they ended up, fairly immediately in a hospitalization or another intensive type service as well. We interviewed 49 parents who came from all over Hennepin County, and kids with lots of different kinds of mental health issues and lots of different ways that they were identified. And the full report talks a lot more about who we interviewed, but we just wanted to highlight kind of what the overall findings were and a couple of the key recommendations. These are services that we asked about, just so you can get a sense of what kinds of services people were thinking about when they answered these questions. Every parent that we interviewed said they tried to get a diagnostic assessment. Almost all looked for a mental health service, which was a big catch-all category, but basically Western mental health services. Typically, for most of them, it was outpatient-based counseling or therapy. For some, that was something more intensive. Most of them looked for educational supports. This wasn't school-based mental health. School-based mental health we talked about as a mental health service, but it could be things through special education, getting a 504 plan or an IEP. We asked about community-based programs that parents might have looked for to support their kids' mental health, which included things like sports or art or mentoring programs, medication, and then other healing services, which for many of the families included things like cultural-based or faith-based healing services, or things like nutrition or acupuncture or other therapeutic services. So that's the array of what we asked about. We identified 6 overarching themes, although we have key findings related to each of those types of services. But across the board, parents talked about how difficult it was to understand the mental health system, to try to figure out where to go, who to help them, what to do next. They had trouble. Almost everybody searched online. They talked a lot about starting with a Google search to figure out what to do for their kid. And then typically not being able to find what they were looking for there. There's no central point of information, for example, and information is hard to find. So that was a really consistent theme, was just how difficult it was to find anything out. The second theme that came up was that parents talked a lot about their own stress and anxiety that they experienced as part of this process. The stress of trying to find services, the stress of worrying about their child. Many talked about stigma and feeling guilt or shame and struggling with that, and often feeling like nobody asked them how they were, that their kid's provider was pretty oblivious or disinterested in supporting what was going on with the parents or even other family members. The third was that having a professional help them made a tremendous amount of difference for the families. So for some, for example, they were connected with case managers. Some had a navigator that they worked with. Sometimes that was through healthcare. So if, for example, several mentioned that their pediatrician had a social worker who served as a behavioral health navigator for them. Or for some, it was, if they were in hospitalization or partial hospitalization, sometimes there was someone there that helped serve that role as well. But having a professional who knew the system was powerful in helping the parents identify not only what exists for services, but helping them figure out which ones were the right fit for their kid or for their family and how to access those. Most of the parents we talked to did not have that kind of support, but if they did, it was very powerful. The fourth was just the importance of peer support. Every parent we talked to highlighted the importance of connecting with peers, often describing processes of starting with their own friends and family, and then eventually wanting to find the people that, like other parents of children with mental health needs. And that was sometimes support groups or just parents that they met individually. That was really important. Fifth was just how hard it was to get services once they found them. They talked about long delays in getting services. Hospitalization certainly came up here, but also access to a psychiatrist or other trained prescriber, diagnostic assessments, just across the board, feeling like it was hard to get what they wanted once they found it. And then finally, a really pervasive theme was how much parents felt that they were in a position of needing to actively fight against providers to get their kids' needs met, that they were always feeling that they were working in opposition. They rarely described feelings of partnership, feeling like they were told no a lot, that they were dismissed, that they were told that, that the issues that they were concerned about weren't significant, things like that. So those were the big themes that came up. And again, each of the types of programming, we have additional findings, but those are the overarching themes that came out of our interviews. And then I just want to highlight a few of the recommendations that are, I think, important regardless of where you are in the system. One is just, we need to continue to do more to make sure that parents can find information when they're looking for it. So thinking about what kinds of things we are individually or collectively creating to help parents understand what's available and how to find it. Second was anything that we can do to help increase parents' access to peers is really powerful and important as well. So offering opportunities through a program or through an agency to connect with peers, or identifying that as a need that people are more explicitly helping parents find support groups or find individuals to talk to. Third is increasing navigation support. And as it relates to, for example, to hospitalization, part of where a navigator was really helpful was in managing transitions. We had a lot of parents where if they did end up in something that was more intensive or restrictive, they lined up services and then they had a hard time transitioning back. So for example, people talked about being stabilized on medication and then not being connected to somebody in the community that could help them, and relying on people who wanted to change the prescriptions, or, it was disruptive to make those transitions. So people who can help navigate that is important. And then fourth is just continuing to think about family-driven care and family voice and how we are embedding that in every service and program that we offer, and how to center parent perspective and parent voice. And there's a lot more detail about all of those. The Hennepin County Collaborative is launching initiatives related to those ideas as well. And then there's a number of other things that we highlighted as important as well, as pretty consistent recommendations. So thinking about how we make services accessible and convenient, strategies to promote behavioral health equity, again, in any kind of service that we're offering or any part of the system, developing and strengthening the workforce, diversifying and strengthening partnerships, which in the report we talk about things like how to bring some of these alternative or other healing practices into settings where we're also doing the kind of the Western mental health as one example. Providing financial support to parents to help them address some of the insurance limitations that they face. And then we have a number of recommendations around public policy as well. The full report is 80 pages. That's the 10-minute version of the full report, but I'm happy to take any questions or comments, or Laura, if there's something else that you'd like to highlight from that.
No, I just think it was when we were doing some planning for the meeting, we wanted to make sure that we brought forward some of these recommendations to add to the conversation, since we have this in the report, but we have several of the parents who were part of the interview process, and of course all the parents here have their own personal experiences to bring to today's conversation. So if we have just a couple minutes, if anyone would like to ask questions of the process, otherwise we can hold off and then bring them forward later. But Joy, yeah, please jump in.
Wasn't sure I raised my hand. I'm like, should
Yeah,
I be raising my hand somewhere? But I really love that concept of the behavioral health navigator, and just wondering if you can share a little bit more, if that's a clinical position or a social worker, or is it more of a volunteer kind of layman type role? But I've seen that in many other aspects, and just curious how this one functioned in supporting our families.
Yeah, it's a great question. And there's a lot of different ways that can look depending on the system. I think part of the, like a number of different kinds of people could be a navigator. Part of what makes a navigator different from just being a peer support is that there's training involved, that it has to be somebody who actually can kind of bring some of this knowledge about the system, but that could be a social worker or a mental health provider. It can also be a parent or peer, if they've gone through some of that navigation training and support, and many agencies, I think, take that route of training a parent to be a navigator. But it's definitely more than an empathetic ear, which is important to parents. Needed the empathetic ear quite a bit, and somebody who actually can say, oh, I know how to get you that, like, let's make that happen, let's connect you, let's make that referral, let's cut through the red tape, let me explain to you this array of services and help make that connection.
And Joy, just to jump in from a community level, some of these families have either had or currently have a mental health case manager that they qualify because the child has a mental health diagnosis. So it unfortunately varies a great deal between counties and how that works in terms of single counties versus different county kinds of things. But oftentimes that person can play some of that role. I think to Cheryl's point, no one can play all of those roles. And certainly the case manager's job is to be kid first, but still they find themselves playing that role a lot. And I think a lot of families feel like their case, if they have a bad case manager, they feel like it's really bad. And if they have a good case manager, they feel like it's been really great. So it can be a really impactful position. And typically they're bachelor's level, maybe sometimes master's level, but typically that's not a requirement.
I thank you. And I think it's like that single point of contact of someone who may not know everything, but they know how to get you to where. So I thank you. I appreciate that comment.
And for some people that was through their insurance company. The challenge there is that the insurance company can do a good job of telling them who in their network they could serve, but not necessarily that full array of like, oh, there's also, an adaptive gymnastics program that would be a great fit, or here's how you can navigate getting some support through the school. So, it depends a little bit on how broad that role is, but having somebody who can help them figure it out was really helpful.
I think if we could just take 2 more minutes, I think Wendy, in Ramsey County, you've been focusing on this as well. Do you want to share your screen maybe and offer up?
I'll unmute myself and do that just real quick. So I will just show just real briefly what we've done, which is, it's funny to hear you talking about it because so much of it seems very similar to the process that we went through a few years ago. Are you able to see my screen right now? Yes? Okay.
Yes.
And so I think several folks at Children's already know about this, but as you're talking about the navigator position, that's very similar to what we also are doing through our collaborative. And I just wanted to show at the bottom here, Cheryl, my gosh, like right on point with what our families are saying that they need, right? So those multi-generational holistic supports for the whole family, things that are free and flexible, very, very short intake process, no time limits for services. So they like to stay with the family as long as they can once they find a home where they feel comfortable, not blacklisting for missed meetings and no-shows. So all of these kinds of things that we already kind of talked about, very, very similar. Healers and providers that reflect the community, having that one point of contact that can help support the whole family. And so in our collaborative, the way that we do that is multifold. And so our whole family support team provides resilience, coaching, check-ins, resource navigations, connections to local services, short-term care coordination, where what we're doing is we're either helping the family build a care team, or if they already have a lot of folks on their care team, we're maybe helping them communicate a little bit better, and then we step back. We can always jump back in again if the parent or caregiver asks us to do that. And so very, very similar to what you guys are talking about is what we are working on. It's always free, always ready to jump in as quickly as we can. And I think that's where our relationship with Children's Hospital has been so incredible, because when a young person does not meet criteria for inpatient hospitalization, when they go into the emergency department, they can make that quick referral over to one of our family support staff, and we just wrap that family around with the needed supports right away and get them connected up in the community. So I'll stop sharing. We don't need to talk too much about that. I want to hear more about Children's and what they're doing.
Thank you. So clearly, as community partners, many of us have been working on this and thinking about this. So again, we're just really grateful to have the opportunity to hear what you're doing, what progress you've made since we've talked last in December, and we committed to having a dialogue around some of these transition points, because we know how critically important they can be as you're working with children and their families in the inpatient setting, and as we as families are supporting their children and providers are supporting families as they leave. So Jamie, I know you wanted to share your screen.
Yes. Yep, I will share my screen. All right, are you able to see my slide?
No.
No.
Oh, it's coming up.
Oh. Yes, no.
It says double click to enter full screen mode.
Oh. Let me try again.
Okay. There you go. We can see.
Nice.
All right. Well, as I said, my name is Jamie Winter, and I'm the Director of Mental Health Services at Children's, and am really privileged to work with just an outstanding group of individuals that are on this call. And so in no way do I want this presentation to be just me talking about some of the stuff we're doing, but welcome them to jump in or questions as they come up. But really wanted to really first talk a little bit about a review of some of the things that we are hoping to do here at Children's that we've been working on over the past couple of years of building out our mental health care continuum. And then we'll jump into kind of updates and new items since we met last. And then want to leave time for Q&A, but then also our children's team has some questions for this group that we were hoping to get feedback and insight on as well. So the first couple of slides will be a little bit of an overview for those that were able to join last time. And so I'll go through them a little bit quickly, and certainly if there's questions, happy to speak to any of those. So really thinking about kind of what we've seen at Children's over the past year is just a really large increase in the volume of kids presenting to emergency departments with a mental health need. And so about a 30% increase, and really our largest historical volumes in our 2 EDs related to an overdose, a suicide attempt, or other mental health crisis. So representing about 2,200 kids last year. We're also seeing some disproportionate impacts on our children of color. So 18% of the kids that we saw in acute mental health crisis were Black. And then also, I think really echoing probably some of the challenges that others on this call have felt as well is really challenges with getting kids to the right level of care. And so understanding for about 850 of those children that came to one of
So Jamie has frozen on my screen.
Yeah, mine too.
Okay. Jamie, if you can hear me, it might be helpful for you to turn your camera off. It will not stop the share screen. And another option is if we lose you, if somebody else has the slide deck, we can, if you want to share it, I can pull it up on my computer. Or somebody can jump in for Jamie.
I am wondering if she is going to log back in.
Right.
I've been on some other calls where folks have just been like booted out of a Zoom meeting and then needing to come back. So.
While we're waiting, can I ask a quick question? So I was noticing that we said that we were seeing more African-American or Black youth in the ED. When we look at the Ramsey County numbers, historically over the last couple of years, it was trending higher for Asian youth in particular, girls, female Asian youth. Wondering if that's still also something that's trending higher. I was just seeing that, the only one that we were highlighting there was our Black young people.
Oh, are you guys able to hear me now? I think I lost you.
Okay, Jamie. Yes, I'm sorry. And I interrupted while you were gone and I asked the group a question.
Oh, great. No, go for it. Yeah.
If
Jamie,
you don't know, that's okay. Oh, go ahead.
The question was around, I pulled up the slides from, and just in case, Jamie, if, but I can certainly stop sharing and you could share your screen again. But the question was around, are we also seeing Asian youth or just an increase in our Black population?
Yeah, that's a really great question, Wendy. I would say the most kind of disproportionate has really been around our Black youth, but certainly happy to pull some of those specific demographic pieces around subsets of race to see if, I think what we notice has been around that one area, but certainly kind of overall, all volumes are up. And so happy to pull additional data.
I would like that just because I think that also is a change then from what we've seen. And so it might help us understand a little bit where we're directing some of our efforts. So thank you.
Absolutely. Yeah. So also wanted to share this slide. And so hopefully this isn't a new slide for those that were able to join us last time, but really, at a high level, this is how we think about our continuum of mental health services here at Children's. And so really thinking about on the left side, the lower acuity. So really focused on screening, early identification and intervention. And so we've worked hard over the last year to 18 months to embed mental health providers within all of our primary care clinics. And so we're hoping to complete that integration this year. We currently have 3 positions open that will get us to all 9 of our primary care clinics across the metro. And this, I would say, has been one of the most impactful pieces of our continuum over the past year to 18 months as we really think about that access to care. So our integrated behavioral health providers often have same day, next day, same week access available. And so when we think about really that piece about getting kids to care quickly, this for us has been one point that families have really responded well to, and really also like that kind of warm handoff between their trusted pediatrician to a mental health provider that works in that same clinic. And so when we look at kind of rates of kids and families that are able to complete services, being co-located in their primary care clinic has been something that for us has felt really good. And so that's one piece of our continuum. As we look at kind of the middle part of the continuum, those are our specialty services. So our more traditional mental health clinics. So we have our psychology, psychiatry, developmental pediatrics, eating disorders programs. And then we also have providers that are embedded within many of our specialty clinics. So places like diabetes endo, gender health clinics. So clinics where we know kids with maybe primary medical concerns also often have secondary mental health needs, or there are mental health needs associated with having a complex medical condition. And then really, as we move towards the right of the continuum, the red boxes represent new pieces to our continuum that we haven't previously had. And really, as we get more to the acute care side, this was where we felt like many gaps in our continuum were. So as we thought about what services we offer, really felt like we had an opportunity to step into this segment of the continuum in a more substantial way. And so this past summer opened our first partial hospitalization program in Lakeville, and then have plans to open a second PHP as we get towards the end of this year. Right now we're looking at kind of St. Paul Metro and surrounding suburbs for the location for that. And so really thinking about how we will allow kids to transition along the continuum. So that I think is also important for us when we think about those transitions and being able to more seamlessly step kids up or down in level of service intensity. And then under the crisis stabilization bucket, historically these efforts have really been led by Nikki and Joy and their team in the emergency departments. And I know before Nikki and Joy, you guys jumped on, Wendy had shared some really great feedback from her team around kind of partnership with the mental health social workers and the ED and how that work has been going. And so really, I think really phenomenal work and really thinking about how do we, step into that space and fill some of the needs for families who maybe kids and families who don't meet the criteria for inpatient placement. And so certainly have valued our partnership with the counties in that space, but also thinking about, how we get kids to services. And so we just announced our partnership with Washburn for the in-home crisis services. So similar to what Alina has done through their WARM program, we will be extending the WARM program into Children's and are excited to talk a little bit more about what that looks like and how we really hope that will help kids get the care that they need in the event that they don't meet criteria for hospitalization. And then on the very right-hand side, one piece that we've really been working hard on over the last year is thinking about our new inpatient mental health unit. And so this is a level of care that we previously have not provided here at Children's. And so really thinking intentionally about how we step into the inpatient mental health space and partner with children and their families when they need those more intensive services. We'll be opening a 22-bed child and adolescent inpatient unit on our St. Paul campus later this year. And that will really complement other services that we do currently offer. So we have our medical stabilization program for eating disorders, which is also on our St. Paul campus. And then we do provide psychological or psychiatric consultation for kids who are boarding or potentially who are seeing us for other reasons or admitted on one of our medical units. So I'll pause there. Anyone from the children's team, anything that you would add or any questions about these pieces?
I have questions. I always have questions, but I'm willing to hold them. I want to throw a couple of them out, like as an asterisk to come back to. So I don't want to lose it. The first one is our crisis group has really been asking how it is that providers can better see easily accessibility or availability for your Lakeville program, in particular, the PHP that you have, similar to how Day One, if you know what that is, where they can go on and they can see what beds are available. They're really struggling right now when the more intensive options are really booked out for quite a long time, and they don't know how to get a referral into some of these services or which one to try. So that was one. And then the second one has to do with the Washburn in-home crisis warm program. But are you going to talk a little bit more about that, Jamie?
I will. Yep. Yep. Perfect. Yeah, so also wanted to kind of bring some of the new things that we've been working on or updates from when we met last. And so I'll talk a little bit about kind of what's been happening since we had our last conversation in December. And so we're excited to say that construction has begun on our inpatient mental health unit. So that started last month. And so this right now, we have a tentative open date of October 17th. And so really fast and furiously planning for how we will be able to open this inpatient mental health unit and start serving kids and families. Dr. Chawla and others from our children's team have been navigating the legislative process for our bed moratorium exception. And so that is something that has also been top of mind for us as we seek additional bed license to be able to provide mental health services for kids. We also have had some success hiring some of our key leadership positions, so specifically around nursing and social work, that will help us really lead our inpatient mental health unit. We have finalized some of our plans around posting and hiring for new positions to support this unit. And so many of those positions will start to get posted this summer and really working on kind of what does that look like to bring on new staff or transition staff from within our other departments that are really excited to work on our inpatient mental health unit. And then really just working hard to finalize some of the decisions around care model and develop our unit procedures. And so I think this conversation is really well timed because I think as we start to think about, what does a day in the life look like for a patient and what are some of the things that we can do, whether that be through connections or care coordination to really streamline that patient's care and help them be successful post-discharge. I think those are the things that we would really love to continue to partner on and think about how we can do that thoughtfully in a way that is really supportive of children and their families. So then I'll talk a little bit about our second PHP. So we have narrowed down our search for a location for that second PHP to the St. Paul metro area and surrounding suburbs. So again, really trying to be mindful as we think about kind of stepping kids down from services. I think some of the feedback that we've received is, it's really great that you're stepping in to fill some of the service gaps, but Lakeville's really far for some families to get to, and not wanting to limit access to services because of location. I mean, certainly, Lakeville was a piece of the market that didn't have that service. And so we felt really good at that point going into that location, just knowing that the South Metro really didn't have much for more intensive services, but absolutely recognize that many of the patients and families we serve come from our metro counties, and we need to be able to serve them well also. We're currently working on design and then hope to move to construction this summer. We are targeting an open date of December of this year or potentially January of 2023, just depending on construction contingencies and lead times for items. And this program will be bigger than our Lakeville one. So one other piece that will be new for us is currently in Lakeville, we only serve adolescents. And so this program, we're really proposing 3 groups. So one group of high schoolers, one group of middle schoolers, and one group of elementary age kids. So really thinking about how we better serve those younger kids that need more intensive services or day treatment. As Wendy mentioned, we have finalized our partnership with Washburn. And so really looking at kind of what does that look like and how will that work with the work that we're currently doing in our emergency departments and as we partner with other organizations in our communities. And so what the partnership with Washburn is for one in-home crisis clinician to support kids who come into children's emergency departments, so similar to the WARM program at Alina. And so for kids who either maybe aren't connected to services or there's an immediate need that isn't being met within the community, they would have access to that Washburn clinician for up to 10 sessions of in-home crisis services. And so really thinking about kids that maybe don't meet the criteria for inpatient, potentially in the future as we have our inpatient unit, could also serve as a step down from inpatient if we're not able to get kids connected with resources quick enough or as quick as we would like to support their discharge plan. And so what we've heard when talking with Alina is really that this has been a nice complement to other services that they access within the community, and it's right for some patients and others it's not. And so it's really understanding for us kind of which kids will be well served by this model, how does it complement our other services in the community. But yeah, Wendy.
How is that same, different, or complementary to the Ramsey County Crisis Stabilization Services?
Yeah, great question.
Or Hennepin. I mean, it would, to crisis stabilization through the county.
Yeah, I don't know, Nikki or Joy, what are your guys' thoughts?
Wendy, we've talked about that explicitly, and I shared, that we've had really great partnerships with both Hennepin and Ramsey County Crisis. And so we've been talking about that with Washburn as far as kind of who they would serve versus who the counties would serve. And I think one of the things they had mentioned was, potentially looking at helping kids who aren't yet well connected with county-based resources, where we might instead really be partnering more with Ramsey County or Hennepin County if they're already plugged in with case management, as people have referenced. But we'll continue to work through that and learn from what Washburn has learned through their partnership with Alina too, because it does seem like that's worked really well for them. And we want to continue to collaborate. I'm grateful for the times that I've been able to connect to with the metrics calls and some of that work where we've got Washburn at the table already, Alina at the table. So
yeah, and I guess what we would love to hear too, Wendy and others, is how is there any precedent that has been established with Alina already? And certainly we value our relationship with both mental health collaboratives, and so in no way is this meant to replace or interfere with those referral relationships. I think it's really seen as an addition or a complement to services depending on kind of what children need. But I think we still are defining the criteria of what that looks like and who would be served by this, but certainly welcome feedback.
Well, and as a collaborative, so we wouldn't be providing crisis stabilization services ourselves. We would be making a warm handoff to like Ramsey County Children's Mental Health Crisis Team, or I think it's the important thing for us is to really understand what the difference is so that we can get families connected, or we can work with them. If there is a difference, or if it's complementary, or if it's very similar, but this is this path and that's another one, it just will be helpful for us to better understand what that is.
Absolutely.
I'm wondering if any of our parents who are with us might have some insights here specifically that would be helpful.
Jacinta had a log off, so.
Oh, okay. Okay.
Yeah. So.
What's the specific question? I'm sorry. I've got.
I'm around. The question was asked about how might the partnership with Washburn, who is serving children and youth who are not moving into the inpatient unit, how they might work, same or similar, different than the crisis mobile services offered through the county. Did I word that appropriately? Maybe.
Yeah, I mean, I know things have changed too and improved with the crisis mobile, but my understanding is Washburn, I think it's a longer term relationship working with families. I know when we've had to call crisis to our home, it's been 1 or 2 visits, and then we follow up with our primary psychiatrist after that, or psychologist. But I know we've had several services from Washburn, from case management to types of in-home therapy, and different levels of therapy based on crisis. But I think it's a more ongoing and long-term relationship than the crisis team, if that makes sense.
I'd just like to add that the family response stabilization pilot that Hennepin County is doing right now, that might also inform this, because they are hoping to intercede a little earlier, but they have some mechanisms for handoffs and are addressing some of these issues as well.
And I know there was, we had our case manager through Washburn, who we saw usually like once a month, and we could do it more, but then we had a crisis case manager who we could see up to a couple times a week, who also did visits in the hospital. But was, and more, I would say that was a more direct service as well, working with our daughter.
I have actually just a quick question about the partnership with Washburn, which I know is a great program, but is that going to be funded through the participants' health insurance then? So kids who have insurance, either private or public, that'll be one criteria for being able to be a part of that program or be a part of that service. Okay.
Yeah, it's a really great question. So Washburn as the treating provider would be the billing provider. And so I certainly do think if a family has insurance that they would bill insurance. I guess I'm not as familiar with their process around families who are uninsured or underinsured. And so I'm certainly happy to take that back and get some clarity kind of around what Washburn's process is for those families who have the financial need. They are also a not-for-profit. And so I think there certainly are opportunities for care delivery, even if a family is challenged financially to pay for the services. Yeah.
I think that's just one of those things from a family perspective that can be really difficult, is there can be a lot of really wonderful programs available. And if it doesn't fit with insurance, and I think we've talked about many folks have left even crisis programs with referrals to places that they can't use because of a variety of reasons, including often if you have private insurance, and there are some things that aren't available to those folks too. So I think that's one part of transition, that when you talk about navigators or other people that are there to help, that they can't answer those questions, but can maybe help cut through some of that. And I know I've had to say, even with a child, was given referrals out of crisis for places that weren't open or had no openings, so I think that's part of that that navigation piece as well, is having the programs, but also knowing how to help people get connected to the services that they need and that they can access is really that piece, especially leaving the hospital.
Absolutely. Yeah, I think that's such great feedback. And I would agree is so important. And I think that's really important for us to, as we think about kind of what does that thoughtful discharge look like and how are we setting families up to be successful after discharge with resources that they are able to access. So yeah, really great feedback.
Yeah, access sometimes also is dependent upon case management status, because there were certain services that we could only get if we were open with a case manager first. So that's just another thing to keep in mind too.
Yeah, great. Okay. A couple of other things I would just call out. I think the other thing that we have been thinking about is kind of what does the mental health workforce look like? I think that certainly is not unique to Children's Minnesota or even to Minnesota in general, but nationally really seeing how do we meet the demand for the increase in need for mental health services. And so some of the things that we've been thinking about is how do we expand our training opportunities? And so and how do we really help contribute to the mental health workforce? And so we've expanded our postdoc psychology training program. So we have 3 additional postdocs that will be starting in September. And then Joy or Nikki, anything you would add about some of your paid internship opportunities?
Yeah, I mean, I can certainly share that we're excited to have some paid internship opportunities. We've had master's level clinical social workers embedded within our team for years, but have goals to have 10 clinical social workers kind of working throughout our system in this next year. And I know that our colleagues in music therapy and child life are also able to get support for paid internships. So it's really exciting to be able to add that additional support to our professions and to build our workforce in the community and at children specifically.
Yeah, thanks, Nikki. And then as I touched on when we were looking at the continuum slide, the other thing that we're really thinking about is how do we move a little bit more upstream? So a lot of our new initiatives have been focused more on acute services. So how do we react when kids are accessing us in crisis, but really also need to continue to have that lens on proactively meeting kids' needs when they're visiting us in a primary care clinic or in one of our specialty clinics. So thinking about that screening, early identification and intervention pieces. And so this year we will finalize the integration into all 9 of our children's primary care clinics of mental health providers. We currently have 3 positions to support this effort that will then round out a workforce of about 12 clinicians embedded within primary care. One of the programs that we currently offer in our Minneapolis primary care clinic is Healthy Steps, which is a program through 0 to 3, really focused on kids 5 and under and early childhood mental health and school readiness, thinking about parental attachment and forming good kind of family relationships. And so thinking about how we could potentially spread that program to other sites, specifically our clinics in St. Paul and West St. Paul. This program in particular is one that we have, had meetings with different kind of parties as we think about how do we offer services that can meet our patient and family needs. And so I think this is one that we really want to be able to continue to grow, just recognizing that joint visits with a pediatrician and a mental health provider or Healthy Steps specialist, as we call them, as we think about, building out kind of talking about what is developmentally normal, when to seek care, thinking about kind of some of those anticipatory guidance and additional education for families, and really having that resource to parenting support. Part of the Healthy Steps program is a parent support line to be able to call with questions. And so really thinking about how we spread that model to other clinics to really do some of the early identification and intervention services. And I will pause there. I'd love to, anyone from the children's team, anything that I missed or anything anyone would add. And then I have one more slide too. We have, our team has some questions that we'd love to ask, but wanted to first open up the opportunity for any questions about the content that we provided today.
Is now a good time to circle back to Wendy's other question about how do providers find
Absolutely.
out about open beds in your PhD?
Yeah, it's a great question, Wendy. So right now, I would say the best way to find out about open beds in PHP is just through calling. So we have a direct intake line, but it's a really good point that I think as we continue to build out our mental health services, making the kind of knowledge about access more readily available and integrating into some of the existing systems is something that I can absolutely take back as a to-do as we think about kind of how your teams can know when we have either beds or spaces available.
So I was a secret caller
Yeah,
on some lines recently because what we've been hearing from a lot of our providers is not just from Children's Hospital, so don't take this in that way, but
no.
There are just these very, very, very long wait lines that we all know exist right now, right? And what we're hearing from providers is this extremely high level of frustration because in order to make referrals, they typically have to make the referral through a website form or leave a message, and then they might hear back within 24, 48 hours. By that time, they are finding out that it's a 7-month to a 10 or a 12-month wait, and then they've got to call another one, right? And so it just, with the capacity of our workforce being what it is right now, there's not enough time on their end to be making all of these calls. And so I wanted to kind of see how it worked. And same thing. So I made a call, like you said, to your PHP line to make the referral. And it was not successful. I tried it 3 times. By the third call, I told them who I was.
Yeah, sure.
And I said, this isn't my first rodeo. So, and then they said, yeah, I think you just need to go through the online form. And I said, all right then.
Yeah. Oh, I'm so sorry that was your
I
experience.
think, but I think it's telling that maybe there's something that has to happen. So I will just bring back just a little bit of feedback that I got when we started saying, what's realistic, because what we heard is that it is really hard for day treatment, PHP, and other providers to be able to know exactly what bed is available at any given moment. And there's all kinds of moving parts, right? But we said, would it be possible, and I'm just gonna pull it up here a little bit, could we develop some sort of a list across some of those more intensive services that described who is open for intake, who is full, who has created a wait list or a callback list, and who is absolutely full? I mean, maybe there's just a way that come up with different terminology here. We're not going to have to do it the same way as day one that says, there's 1 bed for, this particular shelter. That won't work for this, but there's got to be a better way. I mean, I said, how can we get creative so that our providers can find this information more easily? So just wanted
Absolutely.
to share that.
And we would certainly be happy to partner on that. And I think, we certainly also experience the long wait times. I won't, want to be transparent about that. And I think right now our PHP is scheduling our intakes out into June. And so I do think, when we think about kind of access to those immediate kind of higher level day treatment services, we also experience a wait, but I think certainly thinking about how we better partner to make that visible to you and your teams so that it's not something that feels frustrating. And certainly I know kind of that challenge of calling around to lots of different places and not getting the answers that you need is really hard. So I think we certainly can take that back and continue to think about how we do better, but would also welcome any collaboration around kind of
Absolutely.
visibility.
I think if we could walk away from this conversation, I mean, just knowing that you're open to maybe coming together with some of the other more intensive providers and coming up with some creative short-term solutions. We know that, you know, creating something bigger across all of Minnesota would be lovely, but what can we do right now in the short term to be able to really address some of these super long wait times that we're seeing and make it easier for people to find who might have a service in a couple months instead of 7 months, who might have, you know, something available that way would be really helpful, I think.
Yeah, absolutely. Thank you, Wendy.
Can I ask a question along that lines? I don't, if there are other people who want to ask, I can hold on. I'm actually wondering, I know in many of the hospital systems, you know, there's daily reports on number of beds, and then they're called into the larger system. And especially during COVID, we had like daily reports and we knew exactly how many beds were available. So we know we can do this. Is there, but I know, I mean, I'm not, it's not a criticism of anyone, because it takes daily intentionality, and it takes staff time and resources. So is that something that is a possibility, or have we seen this work in any of our other mental health systems? So or do we need to create a new system? Like, can we build on what we know exists for the hospitals? Because we want to include the PHPs and some of the other providers.
Jamie, I
have
can take
something we can build upon.
Go ahead.
Well, when I think of too, I mean, so we've been, Laura, we've been in that totally same position, because as we look for beds, we're in that same position, wondering who has capacity. It's you know, it's kind of like a secret handshake in terms of knowing how to get in. And so I think we share that hope, because we've been on the other side of it. Like, how do we have more transparency? Yet we also have that balance. We know, you know, systems are managing their own EDs, right, before they take in community calls, right or wrong. It's what we've experienced. And so I think that's what we're interested in looking at. How do we really ensure the kids that need the bed the most get it? And that may be a kid in our ED, it may not be. So I think that's what we're looking to build and to figure that out. But, you know, Nikki, when I think of what your team does every day, you know, around the clock, we're just calling every facility saying, they have one open bed. They might have a discharge at 10. So it is intensive. And I would say not as transparent as one would want if it's not your own system. So I think that's a huge opportunity.
Well, I do think that, you know, we do rely on some level on the Minnesota Mental Health Access, you know, page that does list all of the varied levels of services and would be able to list PHP. As I'm looking today, you know, it gives me some hope that there's bed access in the community, but oftentimes all we see there is 0. And so that's to Joy's point, when we really are just calling and trying to ensure that we can get kids connected. And that's typically for that kind of acute intensive inpatient referral, but I appreciate the call out around PHP.
Yeah, I think also oftentimes a lack of beds. It's also like somebody mentioned earlier, the workforce issue, because I know we've had struggles in the past getting my daughter into the hospital, sometimes because there's no beds, but sometimes they'll say there's no beds, but there really are beds. There's just not enough doctors, or the doctors are full and can't take any more on their caseload. Or at one point, my daughter needed a one-on-one all the time with her in the hospital, and they didn't have that staffing. So I think finding creative solutions, maybe to share staff or something, could help as well.
And my apologies, Karen, I wasn't trying to interrupt you, but I agree too. I think that COVID exposures have been a really big impact. Both, you know, when we've had the units have had kids who've been exposed or staff exposures. So you're right. It's a good call out.
I think we were also hearing some of that prior in terms of the, you know, prior to COVID as well. And not, I haven't had a child at Children's, so not at Children's, but on the broader spectrum. And I think the other thing with the systems that you're talking about, Wendy, is that I also know I've been in the position of trying to find care for a child that can't find a partial program because you have to have been in someone's hospital. You have to have had the highest level of, you know, one of the high, not the highest, but you know, have had a hospital stay in order to roll into someone's program, we ran into that with Alina, to be honest, and eventually got a really good program for my daughter. But it's sort of the same thing I feel about education sometimes, which is, so we must fail in order, which going to the hospital isn't failing, right? But something significant must happen in order for us to get this level of care that is needed. And we all know that's a little backwards, right? And what everyone's sort of been talking about is doing things earlier on, but that can be really challenging as well. So I understand why it's that way. And I think, Jamie, maybe you referenced that a bit about, people in their own systems, but as a parent, when the hospital isn't the right thing, but maybe a partial program is, it's hard to hear that. So.
Absolutely. And I think that kind of dovetails into some of the questions that we had for this team, and certainly don't need to address all of these, but I think when our team was we met before this meeting, really, some of the things that I think we're wondering, and so, certainly some of the things you spoke to, Wendy, of access and information sharing, I think those are really important things to call out, but we really want to know kind of what would, parents or school, county services, what does a good partnership look like, and what should we be aspiring to, and are there partnerships that any of you have had with other health systems that we should aim to replicate? Certainly we're open to sharing, and looking at not recreating systems that are already working really well. I think the other things that are, top of mind that we're thinking about is really kind of those healthcare disparities that exist in mental health, and what opportunities, this group kind of could think about for partnership with community organizations to address that, or how are you thinking about addressing that? We also are interested in kind of knowing more about what service gaps you would hope that a pediatric health system like Children's would focus on. So certainly we know that we can't be everything to every child, but there may be things that we either should step into or are positioned in a different fashion to be able to do for kids and families. And so wanted to throw that out there as a question. And then really just wanted to think about how we best stay connected with this group moving forward, as we really strive to understand the needs of our patients, their families, and the community. So really open to discussing any of those, or if anyone has any thoughts, we really just were hoping to gain some of your insight and knowledge. So Nikki, Joy, Gigi, anybody else have anything else that you would add from the children's side?
I know one big gap that we've encountered with our family is that wait between hospital and residential treatment. And I know my daughter was in the hospital for almost 2 months and didn't really need to be there for 2 months, but because she was so severe and wasn't safe at home because of her suicidality, they did not want to send her home until her spot at residential opened. So that's another huge gap, and that's another area where beds are taken up and not available for a really long time. Yeah.
Karen, I'm going to send you a link just so that you can see it. I just thought I would share with you. I don't know if any of you have heard about the new pathway to residential that is available. And I don't know if you have known about it, Karen, but it does allow a parent and a provider to get into that residential pathway without having to go through the county and some of those other loopholes that you had to, or hurdles, I should say, that you had to get over in order to access residential. So you might be interested in reading it. I'll send it to you.
Can you send it to us too, Wendy? Thank you.
Yeah, thank you. Yeah, we were able, we got into the residential, we just couldn't, we were just waiting for a bed to open up there too.
Yeah.
But thank you, I'd love to see that.
one of the things that we are going to start doing in Hennepin County, and would love to continue the partnership or communication with Children's and with Ramsey County, because I think what we're seeing is that families, there's such a shortage that families are moving and getting services wherever they're available. Our county lines and our service lines blur a lot here. But really thinking about how do we get, how do we help elevate awareness around what's available and how to access, I think is one of the big action steps that we'll be taking. The system is really complicated. And not only is it hard for families to know where to find it, then even if it's available, as Liz was saying earlier, it's not always available to families because of their insurance. And if their insurance doesn't cover it, then they have to figure out how to pay for that. And that really slows down access to services. So those are some of the things that we're going to be looking at is really trying to help families navigate this. The other thing that we heard, and we know there's some effort going on, but is that peer support, really elevating that peer support. So not only attending to the mental health needs of the child, but really taking more of a family centered approach to this, and helping families access services to meet the family needs. So how is that going to impact the child, but also the family? So those are some of the key ways that we would love to stay connected with all of you in this meeting. There are others, but I won't hog all space.
I did want to say something quickly. It's not an answer, but just an affirmation. I think the first thing on the slide, that is it a slide? I don't know, the PowerPoint that was about connecting, I believe it was connecting hospitals with schools, with case managers. And I don't have an answer for that because all of those systems have their own systems upon systems and constraints. But just an affirmation that when that happens, I think it's the best thing for kids. And I had a good experience actually with it wasn't inpatient, it was a partial program that included case management and a school representative, and it was the best outcome and allowed for the best experience back to school that we'd had in anything. So no answer, because there's barriers with each of those areas and what people can do and can give, but it's, I think, really key for that discharge and that student and all of those pieces. So I'm happy to see the question. No answers. So
no, I appreciate that, Liz. Thank you.
I'd like to affirm what Liz is saying, that with our support group and everything, those transitions in and out of various things are the things that parents are having to navigate by themselves, and that's where a lot of the problems occur, as well as people just sitting around waiting in their basement with their kid who's needs treatment, and it's 2 months that they have to wait in their basement with them. It's just really sad.
Well, I know that go ahead, Wendy. Were you going to say
Go
something?
ahead, Laura. You go ahead. I was just going to share something. If
you go ahead, because I was going to move us to wrap up if there were no other questions. So,
I was just going to. I sent something over to Children's Hospital a little bit earlier before this meeting, and it's just a list of recommendations that our crisis group, our parents and providers had worked on, and some of them were similar to what you're talking about right now. One of the questions I have is, what is reasonable for us to expect hospital staff to cover with a parent or a caregiver at the time at that transition time. So at the time that they're being discharged from either inpatient or the emergency department. There can be a lot to go over, and how much time is truly available at that transition. So is it fair for us to be putting this on the hospital, or is it more of that warm handoff to the kind of resource navigator or one of the collaboratives, something like what we've been talking about, and then that person is going to be doing a lot of that work. So that's a question. I don't know if anybody has any thoughts about that, but
Yeah, I think it's a really great question, Wendy. I mean, certainly would love Nikki and Joy's thoughts too, but I think we're always open to kind of what that partnership or collaboration looks like. Certainly, I think when we talk about inpatient mental health, anything that we can do to streamline, that experience, to really think about getting services for the next child who is invariably waiting for the bed. I think we're always open to thinking about that. We obviously want the experience to be what is needed for the child that we're caring for, but I think what we see and what we expect to see when we open our inpatient unit is that we will certainly most times have a demand for placement. And so I think anything that we can do to partner, whether that's with the county or elsewhere, is always really, I think, a good thing to be thinking about.
Yeah, and I would just add, I think we're partnering with the family. So I think we're going to take the family's lead in terms of what their preferences for community-based resources, and some will naturally maybe already be aligned with some, others won't, yet that still is the right decision in terms of access and just what fits for their family. But I think that's part of what, and I think, Wendy, you said how much time is actually spent, and I think that's such a great question. We spend whatever time we have, and oftentimes it's not enough, right? Because there's another kid that's needed to be assessed or some other pull. So I think if we can more intentionally think about what is that, to actually do more of a coordinated discharge meeting. I think sometimes, I don't know if we would consider it a discharge planning meeting. I think it's like out the door, next one in. So that's where I hope in partnership with the collaboratives, with Washburn, we can have more intentional discharge planning. So families actually feel like they have a transition plan to get back home and then for next steps. So I think that's where I'm excited for that next opportunity.
So Joy, I don't have your email, but I just sent something over to Jamie, so she has it.
Yes. Good, thank you.
But I'm going to share my screen since I can do that. I'm going to just do it really quick. This is something that our families came up with of what they would want to talk about and consider before being discharged. My question is, it's lengthy, right? So when you're looking at the discharge checklist and we're talking about things to consider, do you know who to call if problems come up at home? And what are those care environment questions? Asking about the parent or the caregiver's capacity to provide services. What's the discharge communication plan, those community resources? And maybe at that point, that might be a referral over to some sort of navigator, like through the collaboratives. What is the crisis plan? There's that discharge summary we have for our families. We give them a all-in-one place care binder or something that they can keep on a flash drive. They also have the ability to keep it in a Google Drive. How are we making sure that the family knows where all this stuff is so they can share it with somebody else on their team? All of these other kinds of pieces, they're alphabetical, which is why it's so freaking long, right? But how long does it take to get through all of that and truly have an intentional discharge meeting? So I guess that was my question is, sometimes we ask for too much and then it's not something that's doable. So that's all. I guess I just wanted to make sure that when we're asking for things, that it's something that's possible.
And Wendy, I love that call out. I know that you've shared some of that before, but I think, it may be different in different settings. When I think back to Jamie's care continuum, right? I think when we're doing a discharge from PHP or from the inpatient mental health unit, to go through all of those areas might feel really reasonable, but I'd love to partner more closely about how do we do that in a reasonable way that's supportive to families as our priority. and also like realistic in that emergency department setting. So people really feel set up for success.
Yeah. Yeah.
Yeah, I completely agree with what Nikki is saying. I do think when looking at the checklist, I think there are many components that when we think about, you know, having that little bit longer of a relationship with a patient and family, whether it be a couple of weeks in PHP or at least a week throughout, you know, an inpatient stay, I think we try to tackle most of the things on there. But I think Nikki brings up a really great question of, you know, in those kind of more single visit encounters, what does that look like, and what is, you know, realistic in those settings, and would love to have more conversation about that.
Is part of the follow-up after a discharge to meet with the pediatrician in the system? Is that part of that? Okay. So that could be one of the follow-up places where if you know, if you decide you can't get through all of those items on that list, then it might make sense to do it with the pediatrician, who we heard
Yeah.
through our journey mapping process was a critical player for many families, because they're a consistent person many times in their family's life. Mhm.
One of
Absolutely.
the other things that I think our providers and caregivers both really wanted was transparency from the hospital system in terms of what is the criteria to be admitted to inpatient when I bring my child into the emergency department. Let's really spell it out clearly. And surprisingly enough, a lot of our providers don't truly understand that either. We've done our best to try to put together some little pathways, you know, to explain that. But I think the more and more and more that the hospital system itself can have something that's on a page on their website, that providers and parents can see when they're considering bringing the child to emergency department, really understanding what that pathway looks like, and being very, very clear about that would be helpful. I'll shut up.
So maybe just one final question. Do we want to try to convene again at a later point, or do you want to work with us through the different processes that are in place already and groups that are in place? What would be helpful for folks here? Or do you want to think about it and then come back? This is a created space, so we know that it may not be the best space to do the ongoing work. But it might be. It gives you an opportunity to work across county lines, which can be helpful. I understand that as a provider. Or I'm not a provider, but for you as a provider.
Yeah, I think we're certainly open to whatever forum feels kind of, you know, best for these two groups for us to get integrated in. I know we you know, have Nikki who participates in the Ramsey County, and I think Laura, we're kind of talking about how we could integrate into Hennepin County as well. And so happy to go that route as well, if that's, you know, an easier venue for your teams. But I think we're just open to continuing the collaboration and thinking about how we partner. So either way works for me.
Jamie, I think that our parents and providers too, but our parents in particular want to feel like they've been heard. So what I've heard them say before is that it's just really valuable for them that if you were to read through, for example, the information that Laura provided or the information that I just sent over to you, and then you could come back to them, maybe come to them at a family services committee, for example, and ask some deeper questions. Say, okay, you know, we read all these ideas that you had and we see these, you know, tools that you're using. We have some, you know, deeper questions we want to learn more about. And you're going to get a whole lot of answers from them. And I think that feels better, because instead of us continuously doing these needs assessments and speaking for families, what it means is we as a hospital system have heard the recommendations that community has provided to us. We've read them, and we're trying to have a deeper understanding of what that means so we can implement some of them. Just go directly back to them and share that.
Absolutely. Yeah, happy to do that, Wendy.
Okay, well, why don't we go ahead and wrap up the meeting? We will follow up with some additional ideas. I'll try to summarize some of the notes from the meeting and share those with everybody here in attendance again. And maybe Megan and Wendy and I can do a follow-up meeting and see we'll give each other another month or so to get through some of these notes, bring it back to our teams and figure out the next step. Great.
That sounds great, Laura. Thank you.
Yeah. Thank you,
Thank
everyone.
Thank you all
Laura, for
so much.
pulling this
Thanks,
together.
everyone. Good seeing you.
Yes. All right.
Laura, do you have 2 seconds to stay on with me?
I do. I'm gonna end the recording though.
Okay, great.